Hello, welcome, and thanks for joining us to help choose home when care is needed. A podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guest, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and Core Cubed. Today's episode is number 3 of season 3, and our guest today is Donna DeBlois, President and CEO of MaineHealth Care at Home. There's really hardly anyone in the field who has constantly maintained an active role like Donna has done, from local positions to national positions, and always with, I would say, an educational and a forward-thinking slant. She's a nurse, a social worker, an advocate, a business leader, and she really fulfills many roles. MaineHealth Care at Home, and she'll tell you about this, I'm sure, offers a wide variety of services, all patient-centered and all thriving under her direction. Please help me, won't you, and welcome Donna to Help Choose Home. First off, I want to say thank you very much for taking time out to join us for Help Choose Home today. And before we start, Donna, I would love for you to talk a little bit about MaineHealth Care at Home and let me know what services your agency provides.
Well, MaineHealth Care at Home is a freestanding home health and hospice provider within the MaineHealth system, which is the largest health system in Maine. So we serve individuals from the moment you cross the border in New Hampshire into Maine. And if you're familiar with Acadia National Park and the coast of Maine, we provide services to within an hour of there, and then all the way to the western border with New Hampshire. So we have an average daily census of about 1,600 patients. We provide home health services, hospice services, including a 7-bed inpatient hospice unit, as well as palliative care. What makes us unique in some respects is that we actually serve 9 island communities. So we get there in various modes of transportation. We can get there by ferry. We can go on the mail plane, which serves on the further north of where we are, or you can take the water taxi. So we are challenged with some interesting traveling phenomena on a daily basis. In our agency, we travel over 2 million miles a year.
Goodness, and it sounds like cover almost all of Maine and some unusual parts of Maine that are hard to cover.
Yes, we cover where it's more populated. Yep.
So this recent COVID-19 situation, how has that impacted your ability to provide services?
Well, it's been an interesting phenomenon because when we went into this, we started really looking at our patient census and looking at how do you protect patients and our staff. And so started really looking at triaging and caring for the more acute side of the population. And so we actually saw a tremendous reduction in our census of about 40%. Since that time, it has started bouncing back. We do provide in-home services for COVID positive and persons under investigation. As of today, we have 18 COVID positive patients that we provide care to. That care is provided by a team. So what we did is we trained a cohort of nurses and therapists in each of our 3 major divisions. And they were all fit tested. It's very interesting when you're in the home health and hospice world doing home visits, how to put on personal protective equipment and take it off in a patient's home is not like walking into a patient's room in a facility. It's very, very different. So we actually had to do, when we did our trainings, do some role playing so we could demonstrate competencies. Because the very first COVID positive patient we had was an individual that we admitted on a very rainy day who didn't really have a porch to don on the PPE So he went inside the door and he did that. And when he left, the nurse was in a little bit of a dilemma. Well, where do I take this off? So he went out to the back of his car, and it's a hatchback, and he took it off there. And we're like, well, that's not a good idea. So then it was really interesting what we had to think through to make this safe for everybody. Another example, we had providing care to a person in an apartment building and making sure that you didn't look obvious. So you had to go into the patient's apartment and put the equipment on and take it off, so you weren't raising any warnings for their neighbors. So this has been very, very, very interesting. Because we are a rural state, we are now seeing an influx of COVID patients from out of state who are choosing to quarantine in Maine. So they are coming to Maine, either going to their summer home early or going to a family member's home, and they are isolating for 14 days. So it's been an interesting journey, I must say. I will share, however, that I know one of the biggest issues for many home health and hospice providers in the country has been the availability of personal protective equipment. We are part of a health system that has been very dogged in acquiring this equipment, so we have been able to have that available for our staff at all times. So our policy is universal masking. So every patient in one of their primary caregivers, we don't do it for all household members, gets a procedure mask or a surgical mask. And they are given a paper bag, and that is their mask to be worn when we're in the home. Our staff, however, have a new mask for every home visit that they do, and they just throw them out after each visit.
Wow. Are there guidelines, or were there guidelines, or how does one know when something unexpected like this happens? How do you know what to do? You said trial and error, but were there some universal precaution guidelines or something that guided you? Because we've never experienced this before.
Absolutely. I mean, we followed a lot of the federal CDC guidelines as well as the state of Maine. We were very fortunate. We have a very proactive director of our CDC program who's a physician, and that's gone really, really well. But there are times I would feel almost schizophrenic. We would tell staff, well, the CDC says that we don't need to wear masks as long as unless they're positive. So you just need to, just follow good hand hygiene and all of that and make sure you're safe distancing. And everybody was fine with that. We gave them all the rationale as far as how the droplet precautions and how the disease is spread. 3 days later, they changed their mind. Now it's a better idea to start masking. So we start masking. And staff are thinking we're crazy. So we started to do, and this will be week 7, we've actually have a daily update. And in the daily update, we provide them with anything that's new that they need to know. We also include self-help materials for them. We give them an update of where we are as far as how many active positive patients that we have, how many are there in the state of Maine, how many are there in our health system. And also we actually furloughed our social workers are working from home. And what we started doing was caring phone calls. And we actually had caring phone calls for patients who were uncomfortable with having someone come in the home, as well as for staff who are struggling through this issue, this journey we're going through. We also, it's interesting, have activated our chaplain. He has been utilized a lot by facilities that we go into for hospice, as well as staff and patients. So we try to cover all of our bases, but sometimes it changes so quickly.
The overall theme, however, seems that you are, one is safer at home receiving care than in a congregate setting.
Correct.
So you would still feel that way. What about your nurses that are having to go to the islands? How do they cope with having the equipment they need and being available as needed on those islands?
Well, what's interesting about the islands is, with everything else with the social distancing, they have really restricted the number of ferries that are going. So we make sure, what we do is every clinician comes in, they have a designated 2 days a week that they come into the office, and they pick up whatever masks or gloves or whatever they need for the next several days so that they always have the equipment with them at all times.
Well, you've been in home care for a long time and all over the United States, correct? And many,
Yes.
several locations.
Mm-hmm.
How do you see, I'm projecting for the future, asking you to look in your crystal ball, how do you see that this particular pandemic changing how healthcare at home is viewed and utilized in the future?
You know where I think our greatest opportunity with this? That's a very good question because I did not bring it up earlier. Telehealth. We have a requirement that all patients who are COVID positive or PUI are put onto telehealth.
And what is PUI?
It's persons under investigation. So that means
thank you.
that they've been tested, but they don't have the results back.
Okay.
So telehealth has been huge, and we are fortunate with our business partner that we work with that we have the ability to do telehealth through the tablet, which is a much more traditional tablet in the patient's home with all the peripherals to measure their oxygen levels, their blood pressure, their weights, and all of that. We also have the ability with their product to do this with a smartphone application. So what we are doing is we're offering patients who are uncomfortable with having someone come into the home, and that could be a new admission or someone we've been seeing, the ability to connect with us telehealth-wise through their own device. And that's actually gone well. The other nice thing is we can use the same application for employees. And we've been doing our pandemic self-reporting of our employees through this same product.
Wow. And how long have you been using telehealth at MaineHealth Care at home?
Since 2001.
Oh, goodness, but is there, that's a long time. Congratulations. Is that because you're an early adopter, or is that because of the rural nature of the patients?
Well, I think it's twofold. We're always an early adopter. I pride ourselves in that. Two, it is for the patients, particularly remote patients. So, for example, in our hospice program, we utilize telehealth predominantly for patients or family members who live remotely. So very often if you get an after-hours call from the patient or a family member, it has to do with anxiety or symptom control. This way, with a tablet in the home, they can actually have a video visit with a hospice clinician because we actually triage our hospice patients for telehealth through our inpatient unit. So it doesn't go to a home care nurse trying to help a hospice patient. It is a hospice nurse working with a hospice patient. So that's one of the reasons we did that, and that really works well. So rurality.
This is a consumer-focused podcast, so oftentimes consumers don't really know how to access care at home. So how does one access MaineHealth Care at home?
Well, very often, most of our referrals, over 60% of our referrals at this time come from acute care. So if it's someone in the hospital, that is a determination made when they're looking at discharge planning, and that would be a conversation they would have with their care manager, and they can look at it that way. If it's someone that's in their doctor's office, so it's a community referral, they can do it in a conversation with their physician's practice. Same with long-term care facilities. Because most of the care that we provide is physician-driven, we do have to have a physician's order to admit the patient, but that doesn't mean we do not need a patient's order to go out and assess a patient. The patient can get a free assessment visit to determine if they have home health or hospice needs. A lot of people don't understand that. We also take everybody. So our mission is that we provide care to all that have a need for it, so regardless of payer. So we provide care to the homeless community, we provide care to individuals who qualify for charity care through other parts of the health system. But reality is between 84 and 80% our patients are government funded. So we are very, very heavily government funded as an agency. We do not have a lot of penetration in the state of Maine for Medicare Advantage, although it is growing. We are still primarily fee-for-service.
Primarily fee-for-service and Medicaid waiver. I'm assuming you have a waiver in Maine too.
We do have waiver, but that's really for the community-based long-term care programs. It's not really for the skilled side.
And all of your services are from the skills side, it sounds like.
Correct. We did have a private duty arm to the agency. It did well in certain pockets where individuals had the ability to privately pay for care. But when we started really looking out and looking at the incredible growth in franchises and others who are moving into the state of Maine to provide those services, one, for patients and two, for staffing, it made a huge difference. I remembered my third piece for telehealth.
Oh, good. Thank you.
Did it. Had to do with an aging workforce. Had to do with a limited workforce. And it has everything to do with how can we provide care in a patient's home with less physical contact and get the same clinical outcomes and patient satisfactions we always have. So that's a major driver. We have one of the older working nursing workforces in the country. So therapy's age is not quite so high, but we have we're on the older end, and the retirement cliff is not coming. It is actually here.
But people are working longer, right? Not retiring.
Yes.
They're staying in the system.
It's very interesting. When you looked at the demographics of our staff, about 10% of our nursing staff is over the age of 70, and it's growing. But when I first started here, so this would be 5-6 years ago, 10% were under the age of 30. So most of our cohort of staff were between 40 and 69.
That would make me feel comfortable because I know they have a lot of experience. So.
Exactly.
Congratulations.
Exactly.
Donna, is there something that I have not asked you today that you thought I was going to ask you, or something you would like to talk about that I have not talked about yet?
I think it's really interesting. I think forever the optimist, and I think that home health, and as we embrace technology and we can prove our outcomes with technology, because we are collecting enough data so that we can do that now, we'll start moving our industry to the non-acute side rather than the post-acute side. I think as soon as we figure out how we partner with, our third-party payers, and so they recognize the value and are willing to pay for it, and we partner with physician practices so that if a patient calls in and they want to be seen by a doctor that day, but it may be something that a physician doesn't need to see them for, we could go out through a rapid response team model, or we could do it by embedding telehealth in certain locations, which leads me to one other point we do with telehealth. We actually have telehealth in 8 family and elderly housing complexes, and they're done as a kiosk. So individuals in those units can actually go in and log in and do a telehealth visit with one of our telehealth nurses whenever they want to. And it's encrypted so that it's, their PHI is protected. And also once a month, we actually have we have a clinician go to those facilities for an in-person clinic once a month. And we do this on 2 of the islands also. And I think we need to start looking at those partnerships. What is it that your health systems that you're working with, whether you're part of it or not, what are they doing with population health? What is our role with population health? We have a huge role with population health, because one of the biggest things that we do, the most important things we do as home health providers and hospice, is education. And the only way that we're going to reduce the cost of care is by improving the health of our society. And that's all going to be done through population health. And so I think there are ways that we need to be creative in how is it that we can do this.
Well, I have no doubt that you will find the answers to some of these questions and continue to do what you've done through most of your career, which is make healthcare at home a better industry. So
yes.
I want to thank you so much for your time today.
Thank you, Marilee. It was a pleasure.
Thank you so much for listening today. And a special thanks to our sponsors and partners, National Association for Home Care and Hospice, Access, and Core Cubed. If you've not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. We are now on Spotify, so you can listen to us in all different kinds of ways. Please like and follow us on social media and join us, won't you, to spread the word and help choose home when care is needed.